Vidéo, je ne sais pas si ça va éclairer. Waouh!
Et partager les.
Et partager l'écran, effectivement. Ah oui. Le premier, celui-là. Vous nous entendez? Can you hear me? Can you hear us? Okay. Good. So let's go, and you can maybe ask some questions to the chat or ask if you want to ask something. So, my name is Julien. I'm a pulmonologist specialist in the thoracic oncology, and today we'll speak about targeted therapies in oncology. So this is something like a 2 hours lesson. You can interrupt me, you can ask questions. I have some quiz in the middle to keep you awake. Okay, so let's go. So when I was seated here, I'm not sure it was the same room, but in 2000 when I was doing my Master of Science in oncology, the picture of oncogenesis was that one. I think you are probably familiar with this one. So when I was even a young student, it was cancer was only a growth of tumor cells. We know that it's not, it cannot recapitulate all the oncogenesis, and that we have evading apoptosis, self-sufficiency in growth signal, and sensitivity to anti-growth signal, tissue invasion and metastasis, limitless replicative potential, and sustained angiogenesis. It was written by Anna and Weinberg, and every 10 years they are proposing an update. So that one, you're probably aware also of that one, is more complex. It includes a new concept, including immune destruction. So you know that the cancer cells avoid immune destruction, enabling replicative immortality, tumor promoting inflammation. So this is a new field, inflammation and cancer. It can activate invasion and metastasis, induce angiogenesis. They also added genome instability and mutation, resisting to apoptosis. Something new, and you will have a special lesson on that regarding metabolism of the tumor, deregulating cellular energetics, what I say, and sustaining proliferating signaling. So it was in 2011, and I'll go on that one. And even more recently, they proposed that we can, each part of cancer hallmarks can be targeted through specific strategies. So you have an overview here. For example, if we want to target immune system, we have some anti-PD-1, PD-L1, we'll go back on that. We can use anti-inflammatory drugs. We can target pathways involved in invasion and metastasis. We can target angiogenesis. For breast cancer, ovary cancer, we have some PARP inhibitors that can target this genome instability, and so on. So you see on this slide that we cannot address cancer treatment with only one strategy. We need to identify each cancer with their specific screening pathway, and most of the time to use a combination of the various strategies. And they recently, in 2022, add 4 more hallmarks of cancer, same authors. So Weinberg is working in the US and Anne in Switzerland. And they add that the new so emerging hallmarks were unlocking phenotypic plasticity, non-mutational epigenetic reprogramming. That means that a lot of molecular events do not occur in the DNA, but outside, the DNA mutation, such as epigenetic reprogramming. they also add polymorphic microbiome and the concept of senescent cells. So you see, this is now the whole picture of carcinogenesis. So it's more and more complicated. So we have, and that's why it's complicated to treat cancer, because we have to address in some cancer all of these hallmarks. So this is now the new one. I will say the last version. So maybe in 5 years we will have something even more complicated. So maybe you are working in lab where you will work on something that is not here, but will be the next a new pathway in oncogenesis. So I think all these papers are available, and I will let you the slide so you can go on that. And I don't want to focus too much. It was just as an introduction. If we are, I'm a specialist in lung cancer, even if I won't speak only on lung cancer. If we are speaking about oncogenesis, globally there is two main pathways for oncogenesis. It's true for lung cancer, but it's the same for breast cancer, it's the same for colon cancer. This is something that is very well known, reported for many years. Aggregation of numerous mutation. You start with, some of you are pathologists. No? There is no resident in pathology. Okay. You can start with a dysplasia, and then you have in situ carcinomas and an invasive carcinoma. So I will say it's a step by step. It can take years and years, and it starts with a few molecular events, then addition of molecular events, and at the end, you cross the basal membrane and you have an invasive tumors. So this is what we see for colorectal cancer when you have an adenoma, then switching to adenocarcinoma. It's the same for lung cancer. You have a dysplasia, metaplasia, then dysplasia, then adenocarcinoma. And most of these diseases are treated by chemotherapy and immunotherapy, not by targeted therapy, because there is a multiplicity of gene alteration. So there is not only, we have P53 combined with RB1, combined with KRAS. There are too much molecular events, so we cannot target only one. So that's why we use chemotherapy and immunotherapy. At the opposite, sometimes it's not an aggregation of mutation, it's a single mutation, so a single genetic event. It can be a translocation, it can be punctual mutation, it can be an amplification of gene. And when you have these molecular abnormalities, it will directly transform a normal cell to a tumor cell. And then this is very interesting because if you, for example, if you have an EGFR mutated lung cancer, if you analyze the brain mets, brain metastases with lung tumor or liver mets, all the cells are the same with EGFR mutation. So it's kind of monoclonal disease. And for that one, chemotherapy, immunotherapy are not working very well. That's why we use targeted therapy, if they are available, to target the molecular event, this mutation. So we don't target the mutation, we target the protein issued from the mutation, but it's considered as targeted therapy. Is it okay? I guess maybe you are aware of that. It's the same things, but with a pathological view. If you look at the lung tumor with oncogenic addiction, it will look like homogeneous disease. Almost all the cells looks alike. And you can see here that you have some immune environment, but it's very poor. That's why we use targeted therapy. Immunotherapy or chemotherapy are not working very well. If you look at tobacco-induced lung cancer, you will have this kind of mix, a lot of immune cells, a lot of microenvironment. You have CD4, CD8 lymphocytes, you have macrophage, and you have also a lot of inflammatory cells and some tumor cells. So that's why here it's complicated to treat this disease because it's a mix of everything. And for that one, chemo and immunotherapy are working better than targeted therapy. Okay, just always the same, but with multi-step carcinogenesis, it's a Darwinian selection of clones harboring mutations. So at the beginning, you have some mutation that will give a selective advantage to the cells, and that at the end will lead to this kind of tumor, a mix of clonal expansion of surviving cell variants. So you can understand here that to treat this kind of tumor is quite complicated because it's a mix of various clonal expansion. In patients with an oncogenic addiction, I will say all the cells are the same color, and it's easier to treat. So it's difficult to speak about oncogenesis and not to speak about what you say the best serial killer worldwide. It's considered now that 1 billion patients has been killed by tobacco. So I don't want, it's not a lesson regarding tobacco, but it's important to know that in a cigarette, you have a mix of components that will lead to addiction. So you will buy a cigarette every day. Of components that can cause vascular disease, lung cancer, bladder cancer, a lot of kind of cancer. So everything is in a small cigarette. And this is the most common cause of cancer, not only lung cancer, that it can induce breast cancer, bladder cancer, head and neck cancer, pancreatic cancer. So it's very. So how it works? It works on very several pathways, I will say. You have some carcinogens that will lead to DNA adducts, then change in many important genes, KRAS, MYC, P53, P16, RB, and others that will lead to lung cancer. It can also activate some AKT, so survival pathway. It can decrease apoptosis, induce angiogenesis. So here also, in addition, can lead to lung cancer. And it can also promote some co-carcinogens, carcinogens that are already present in some cells that can be activated through smoking. So that's why it works very well. Because if you smoke, you have one chance, I would say, out of 2 to die due to cigarettes. So it works quite well. In addition, it can induce some inflammation mediated by TGF-beta or some interleukin 8 or other interleukin. So it will induce extracellular remodeling, fibrosis, inflammation, and that in addition with mutagenesis, because the direct action on the DNA, it can induce tumorigenesis. So quite efficient. So as I told you, it was a multi-step carcinogenesis. Today we will focus on oncogenic addiction. What means oncogenic addiction? That means that you have molecular abnormalities that will drive the tumor development. And if you look here at the balance between survival and death signal in oncogenic addictive cancer cells, you can see here that you have more survival than death. So that means there is a tumor development. And if you treat the tumor cells, if you treat the patient and the tumor cells, it will decrease very rapidly the survival pathway, and you will have a very quick and reproducible response. For example, if you have a patient with a lung cancer, shortness of breath, pain, and everything. If you give this patient a targeted therapy in something like 2 or 3 days or at maximum 1 week, he will feel better. It works very well because it targets the survival pathway. So it's what we call oncogenic shock. Sometimes we say for the patient Lazarus response, c'est religieux, mais Lazare, comme une ressuscitation. So it can be, it's very surprising, but it works very well. So how we can explain oncogenic addiction? It's very easy. If the mouse model of oncogenic addiction is you introduce in a mouse model an EGFR mutation, and it's an on-off system, so you can activate this mutation whenever you want. At the end, you will obtain, you see here, after 30 days of doxycycline to activate the EGFR gene, you will have lung cancer. So this is an on-off system. You add EGFR in the mouse genome, you will have a lung cancer. If you treat with the tyrosine kinase inhibitors, after 10 days, it treats very rapidly the lung cancer. So it's very impressive. You can see here the same with KRAS. I don't know exactly this, but you can induce lung cancer. But I think at this time, we did not have a KRAS inhibitor, so I don't have the slide showing the response. But you introduce KRAS mutation in a mouse model, and you will have here a lung tumor. So this is a question. Among the following drugs, which one are considered as targeted therapy? Osimertinib? Yes, no. Yeah, targeted therapy means it targets an oncogene that will drive the lung carcinogenesis. Yes, target. What is the target? KRAS, EGFR, BRAF, ALK. So it's a EGFR inhibitor. So it's a targeted therapy. Nivolumab. So nivolumab, it targets PD-1, so it's an immunotherapy, and it's not a targeted therapy. Why it's not a targeted therapy? Because if you add PD-1 in a mouse, the mouse won't develop a cancer. I mean, you target a pathway, but you don't target an oncogene. Pemetrexed, it's a conventional chemotherapy, so it's not a targeted therapy. Dabrafenib, okay, which gene? It's written in it, BRAF. Crizotinib, yes, it targets ALK, ROS. So what is important is it's considered as a targeted therapy if it targets protein which is involved in oncogenesis. For example, PD-1, thymidylate synthase are important, but they are not, they are not oncogenic. I would say they are important in oncogenesis, but they are not oncogenic. So you have here some example, and I will give you some more examples. Here you have some oncogenic drivers and disease. So, do you think that BCR Abelson is an oncogenic driver for chronic myeloid leukemia? Yes, okay, good. But HPV is an oncogenic driver for head and neck cancer? No. No, so it's involved, but it's not an oncogenic driver. That means if you prevent HPV through vaccine, it's okay. But if you target HPV, you won't have any. EGFR and lung cancer. Yes. HER2 and breast cancer. No. HER2 and breast cancer? No? Yes? Yes. It's one of the very important, in breast cancer. You have a lot of drugs that are targeting HER2 in breast cancer. PI3 kinase and ovarian cancer. It's a little bit complicated because PI3 kinase is involved in ovarian cancer, but it's not targetable, so it's not considered as an oncogenic driver. And SECIT and gastrointestinal stromal tumor, yes. Okay. So each time it's an oncogenic driver defined as there is some molecular alteration, such as mutations, translocation, and involved in the oncogenesis. And we have drugs to address specifically all these mutations. So another question, quite complicated and not even sure of the response. What are the main molecular abnormalities responsible for oncogenic addiction? So it did not translate. It's not surexpression, it's overexpression, punctual mutation, amplification, polyploidy, and translocation. So what we are sure already. Overexpression, that means you have a gene and then a protein that is produced. It's the same, there is no modification in the protein, but it's just in abnormal quantity. For example, overexpression of EGFR, of HER2. So you say yes? Okay, we'll see. Punctual mutation. The mutation, for example, if you say BRAF, it targets the V600E mutation. Or EGFR, osimertinib is targeted the L858R mutations. Is a punctual mutation? Yeah, because punctual mutation, depending at which situation in the DNA, can induce an abnormal protein that can be oncogenic. So punctual mutation is true. Amplification. What is amplification? You have several copies of the same gene on the chromosomes. That means it will induce an abnormal quantity of the protein. So yes, polyploidy. So polyploidy, you have several copies of the gene, but you have many copies of the chromosomes. So no, because it's just an abnormality, but it's not an oncogenic phenomenon. And translocation, that means rearrangement between two chromosomes, such as BCR-ABL, yes. So we agree, except for the first one, as overexpression is not considered as oncogenic. If you said that in breast cancer, HER2 overexpression is considered as a target, but it's because this overexpression is associated with amplification. But overexpression of ALK, overexpression of EGFR, you have too much protein, but if the protein is normal, there is no biological effect. So you need to have a very important molecular event. It cannot be just an overexpression. So that means you need a mutation in the DNA, an amplification, several copies of the gene, or translocation. If not, it's not considered as an oncogenic addiction. It can be used as a surrogate marker. If you are an overexpression of ALK, that means that you have a translocation of ALK. But in itself, it cannot be considered as a... So here you have an overview of the main molecular events that are associated with oncogenic addiction. Here you can have here translocation, so that means it's a mix of two DNA coming from different chromosomes. You can have a gene amplification, as I said, several copies of the same gene. And here you can have some point mutation within the gene or within a control element. Sometimes it's not exactly in the coding part of the gene. So these are the main events associated with oncogenic addiction. So translocation, sometimes you will see a rearrangement, chromosomal rearrangement, gene amplification, or point mutation. It's clear? So how can we make the diagnosis for that? So for computation, it's sequencing. So you can use either next generation sequencing or Sanger methods. You have plenty of methods. Gene amplification, as the gene, the DNA sequence is not affected, you need to prove that you have several copies of the gene. So you will use fluorescent in situ hybridization. That means you will find a probe that will target the gene. And if you have, for example, here, 6 red spots, and you have only 2 green spots, green spot means chromosomes, it's a part of the chromosome, that means you have an amplification. If you have 6 red spots and 6 green spots, it's a polyploidy. Means if you have 6 copies of the gene, but it's because you have 6 chromosomes because it's a monstrous cell. So we use that. In fact, it's very theoretical because we are doing NGS for all patients. So we don't care if it's most of the time we with next generation sequencing, we check mutation. We can also check amplification, and we have probe to detect translocation. So for most of the patients, it's NGS for everyone, and you have the results. But in some cases, you can check with fish, or you can do, for example, if you are in a hurry, if you have an emergency in the patient in intensive care, if you want to have the results in 24 hours, you can do a specific EGFR PCR, for example. So you will have the result for next generation sequencing, something like 1 to 2 weeks. Okay. So this is the same. So you have here the kind of example of molecular alteration in lung cancer. Translocation, you have translocation for ALK, for ROS1, for NTRK, for RET. And most of the time, when you have a translocation, it's presented with the name of, you see, there is 2 names, because it's a mix between 2 proteins. So for example, ALK, the fusion partner of ALK can be EML4, but it can be other one. The fusion partner of RET can be KIF5B, but it can be also something else. So most of the time when you have translocation, it's a 2-part name with the gene of interest, ALK and RET, and the partner fusion, the fusion partner. For gene amplification, we have amplification of MET and sometimes of HER2. And for punctual mutation, it's most of the time presented this way. As I said, BRAF V600E, what does that mean? That means that in a specific exon, I think it's exon 15, in 600 position, you have a switch between valine and, I don't remember what is E, you know, which amino acid is E, leucine, or I don't know. Anyway, here, for example, in EGFR, in 858 position, you have a switch between leucine and arginine. This is a very typical. So this is what we did for every patient. I saw a patient this morning. They are all coming with that. So we cannot treat a lung cancer patient without that. So we have some panels. Sometimes it's a 10 gene panel. Sometimes it's 1,000 of gene panels. But the minimal we are doing in Toulouse is we are looking at all these genes. You can see that some are important because we have drugs such as ALK, such as BRAF, such as HER2, EGFR, MET. But for some genes, we don't have drugs. So it's a little bit complicated because we have the result, but we don't know how to target. For example, if you have a P10 loss of expression, we don't have drugs. But maybe it will help in the future for clinical trials. So this is what we have right now. And we are currently switching to this kind of panel. For example, this is for a patient. So all the genes that are analyzed, and here all the fusions that are analyzed. So you see it's a lot, and we can have this kind of response for this patient. They identified a MET exon 14 splice type mutation. Very good. We have drugs. It's perfect. But they also say you have also some additional disease with no reportable alteration, EGFR, but it's not the right one. KRAS, ALK, BRAF. So no, for that one, you don't have nothing. We have nothing. Here we have only MET exon 14, so this is targetable. And MDM2 amplification, we don't know how. So sometimes you have some information of interest, and sometimes MDM2 amplification, what can we do with that? We don't know. Should we take it into account? Is it kind of something that is not important in the oncology? We don't know. That's why the more gene you have, the more complex results you have. So you have to be very careful to pick up the right genes that are targetable. We are also in the pathological lab at Oncopol. Currently, they are proposing this TSO 500. It's an Illumina company. So you have 500 genes for every patient. Some genes are important for lung, for melanoma, for colon, for ovarian. So you see, you have to deal with all these results. So that's why we need people like you to understand the biology, because sometimes, for example, maybe some of you are working, I don't know, on KIT or MDM2. As a doctor, most of the time when you have this result, we don't know exactly what it means. The other very important point is that to have this molecular profile of the tumor, we use biopsy. PT guide biopsy, endoscopy, biopsy, but it's tissue. But sometimes it's difficult. And sometimes we use what we call liquid biopsy. Liquid biopsy, that means it's a blood sample in a small tube. And we can analyze, having in mind that the tumor will shed some DNA in the blood. We can analyze mutation, chromosomal rearrangement, copy number aberration, methylation, DNA fragment length, and so on. So it's very important. We are using more and more. Why? Because for the diagnosis, it's not the standard method, because we need tissue to say PD-L1 expression, it's an adenocarcinoma, it's a squamous. But so ctDNA just say you have some tumoral DNA, but they don't say it's coming from the lung, it's coming. So we need tissue to have the diagnosis. But after, if you want a follow-up for the patient, if they are under treatment, is there any change in their molecular profile? It's very important because it's non-invasive. Instead of having bronchoscopy, you have a blood sample. It can cover temporal heterogeneity. That means you can perform the liquid biopsy every 3 months, every 6 months. You cannot do a tissue biopsy every 6 months. Spatial heterogeneity. For example, if you find a mutation in a liver metastasis, are you sure that this mutation is present everywhere? No. If it's in the blood, you can probably think that it can incorporate all the changes in the whole body. And you can monitor some subclone. For example, you have predominant clone EGFR and minor clone BRAF, and then you can see that it will cross under treatment. That means you will have to treat BRAF instead of EGFR at some points. So we use it. It's not reimbursed, so it's not performed everywhere, but we are using it in a research purpose very, very often. Okay. Any question? Okay. So you can see here some example. We already mentioned that. Probably that the first targeted therapy discovered in oncology was imatinib, so c-KIT inhibitors in chronic myeloid lymphoma. You can see here This is a drug, and it targets specifically the BCR-Abelson chimeric protein. And it worked very well. As you can see, patients were previously treated by chemo, by interferon. And when we use imatinib, Gleevec, you can see here that there is a survival of a CML patient is very high. So it works very well. So this is one of the best examples of targeted therapy. The thing is, it's for hematological disease. And you know that hematological disease, it's monoclonal. I mean, all the cells are the same. So if you find the right treatment, it will work very well. In solid tumors, breast cancer, lung cancer, prostate cancer, it's more heterogeneous. So it's more complicated if you give a single drug to treat everything. But, so this is the reference. For breast cancer, you have here some example of HER2 induced breast cancer. So we know that HER2 is important in breast cancer. It's something between 20 or 25% of breast cancer patients who display this alteration. And you can see here that it had been discovered many years ago. But now we know exactly how to target this HER2 alteration. And it has been, it was in 2001. So this is the second targeted therapy available in oncology. And you can see here that patients with metastatic breast cancer were treated with chemotherapy alone. And when you add trastuzumab, an HER2 antibody, you see that you have a better survival. So that's why we use trastuzumab. So now we have new drugs. It's not trastuzumab. It can be used trastuzumab, but we have new HER2 antibodies. But it works better than chemotherapy alone. No? The common point of all these molecular alterations are summarized here. It's always the same story. Okay? You have EGFR mutation, I fusion, ROS1 fusion, HER2 mutation or amplification, NTRK fusion. It always targets the same pathway. That means on one end, it will target the PI3 kinase AKT pathway, so the survival pathway. You know that. And on the other hand, it will target the proliferation pathway, so RAS, RAF, the MEK kinase pathway. So it works on both proliferation and survival pathway. So at the end, it will totally block the tumor proliferation. Regardless of the results, is always the same. It always goes through these pathways. So just to let you know how it works for lung cancer, before 2004, we had no targeted therapy. It was surgery, chemotherapy, radiotherapy. In 2004, we identified EGFR mutation in 15% of the patients. So it's 10% in France, it's 40% in China or Vietnam, for example, in Southeast Asia. And now we are here. So that means we have plenty of molecular alteration and plenty of drugs. That means that more than half of the patients are eligible for targeted therapy. So this is very important to see this change. So it's a good point for you that you start your studies now, because it was very boring at this time because we were treating all the patients with chemo, and now you can work on all these genes. They are all targets, and we have new drugs for all these molecular abnormalities. So we have some drugs that are working very well. That means ORR means overall response rate. That means that 80% of the patients have response rate, so it works in the majority of patients. But for some other drugs, response rate is between 20 and 40%. So that means it doesn't work so well. So we have some patients with I would say, very good oncogenic addiction, and we can target them very efficiently. This will be the second part of my talk. We'll speak about resistance, but it works well. That means if you give the targeted therapy to a patient instead of a chemotherapy, response rate is 80%. So you are pretty sure that it will work and the patient will feel better. At the opposite, we have some oncogenic addiction, but either it's a weak addiction or the drugs are not very efficient, but you see that response rate is 40%. That means it's almost the same than chemotherapy. And we have some hard to treat oncogenic addiction, such as TRAS, HER2, for which we don't know exactly if it's because of the target or because of the drug. We have some good results, but it's not very efficient, or it's limited in time. So this is the current picture of lung cancer. So that means that's why we need to do some biology and to study and to understand the biology, because treating lung cancer is becoming more and more complex as you can find EGFR mutation, ALK translocation, MATE, HER2, ROS1, BRAF, REC. So it's very small subgroups, but addition of all these subgroups at the end, most of the patients can have access to drugs. You have here the molecular alternation, and you have the drugs that are available. So you see that for a lot of patients, we have targeted therapy available. So to go back to EGFR, because it was the first discovery of an oncogenic addiction in lung cancer, it was 20 years ago. They made a special issue of New England this year for the birthday of the discovery. And I remember this day very well because I was same age as you, and I was working on that. And I remember the same day we received through email report say there is a very important paper published in Science. And 1 hour later, we received the same email saying we have a very important paper published in the New England Journal of Medicine. It's not the same team, it's US teams, but they discovered at the same time the same finding. That means that only patients with EGFR mutation were responder to EGFR inhibitors. At the beginning, we understood that EGFR was important, so we were giving EGFR inhibitor to everyone. But at the end, only 15% of the patients had a response. So, but we don't know why. So they identified that the key feature of the responder was they had this EGFR mutation. So as I told you, a punctual molecular event, very precise event, and you have that lead oncogenesis, and at the end, you can target this. So I think in the workshop you will have next week or in 2 weeks, you have this paper to read. And so we deciphered the molecular background of response. And you can see here, this is the EGFR gene. You can see here that on exon 18, 19, and 21, all these deletion here, punctual mutation here, are associated with response to EGFR inhibitors. At the opposite, all these alterations, mostly in exon 20, are associated with resistance. So we cannot target right now this. We have drugs, but at the 20 years ago, you see here that all the molecular alteration associated with response with sensitivity were this exon 19 deletion or this punctual mutation in exon 21. So was very important for lung cancer, and we identified the same after for other genes. So nothing new here. So you can see here that with the lung adenocarcinoma induced by L858R mutation, it induced, as I told you, lung tumors. And if you add erlotinib, you can see that it can clear the tumors. So Varmus, maybe you know, Varmus, he has a Nobel Prize 25 years ago. It was not for that he had some other discoveries, the association between virus and oncogenesis. But this is a very important paper confirming that you need this molecular alteration to have a response to targeted treatment. Here it was erlotinib. So what are the molecular events? You can see that we have punctual mutation, antisense mutation, or deletions. So, but it's always on exon 18, 19, and 21, because these exons are coding for the tyrosine kinase domain of the protein. Oops. So here you have all the important sites, and here you have I think it's erlotinib or defetinib drug that will specifically block here this protein modified by the deletion or the mutation. So this is how pharmaceutical companies are doing. They have this EGFR receptor, and they try to target with hundreds and thousands of drugs, and they try to find the one that will specifically block the kinase activity, and they will develop it into the clinic. So it started, as I told you, 20 years ago. And in this clinical trial, patients were treated with EGFR mutation by erlotinib or chemo. And you can see here that erlotinib performed better than chemotherapy. So it became a standard of care. Now we have new drugs. As I told you, it was osimertinib. So osimertinib versus gefetinib or erlotinib. You see that osimertinib is working better. And you can see the survival curve. So if I have to draw here the chemotherapy, it will be something like that. But here you see it's okay, because at 3 years, most of half of the patients are still alive. But I would say it's okay, but it's not enough, because all these patients here are dying despite being treated with the right drug. So it works well, but there is unavoidable resistance. So we made a lot of progress. We know we can identify the target. We can give the right targeted therapy. But despite this, we still have some resistance to this drug. You see that it's not the same curve as the one with Glivec that was quite horizontal. So here you see that it works, but not in all patients. Very important point. I added this year. It has been published last year in Nature. It's regarding pollution. Okay, I think you are all aware that pollution can induce cancer, but this is a very important paper. It's important for the biology. It's important even for our way of life. How can pollution, air pollutants, can induce lung cancer? Do you have any thought regarding that? Do you think it's like tobacco? I mean, if we go to the DNA and induce some DNA adducts and mutation in P53 in KRAS, do you think it's something else? No? Do you think it's a fake news? And there is no pollution, it's your friend followers. So it has been performed by Charles Quanton. Charles Quanton is a researcher in London. He's very famous. If you take on PubMed, you will see he publish a Nature paper every 3 months. He worked in tumor development and multiclonal tumors, but that time he focused on air pollution. And I think it's very interesting because what we have all in mind for oncogenesis is that we have, mutation induced by a product. It can be tobacco, it can be DMDA, it's a chemical agent. And we have a kind of mix with an initiator mutation and a promoter of the tumor. So it's a mix of two events, but you need to have an exposition to an oncogenic agent or something that can induce a mutation in your DNA that will, in turn, induce the cancer. So it's the same for every cancer. And if you want to induce cancer in a mouse or something, you use this kind of mutagenic agents, and it works. So can we think that pollution works that way? So what they say first is to make epidemiological study, relationships between EGFR mutated lung cancer and PM 2.5. You know what is PM 2.5? Particle matters 2.5 micron. It's pollution. Okay? It's small particles coming from cars, coming from wood, coming from fire. So it's small particle matters. So they did epidemiological analysis worldwide in England, Taiwan, South Korea. Second question, PM 2.5 promote homogenesis of pre-existing EGFR clones. So in their mind, they say maybe it doesn't induce mutation, but it will target pre-existing EGFR clone and make them oncogenic. And they will also, if you say that, that means that in normal lung tissue, in your lung tissue, in my lung tissue, we have some EGFR or KRAS mutation, but if we don't have exposure to pollution or to something else, we won't have cancer. So it's very, very, very smart. First, in this biobank of almost 500,000 participants, you say that you can see here that there is a correlation between PM 2.5 exposure with small intestine cancer, larynx cancer, anus cancer, mesothelioma pleural cancer, glioblastoma, lung cancer, and oral cavity and foreign cancer. So I mean, all the organs that I will open to outside, there is a link, a correlation between pollution and cancer, regardless of tobacco and onion. They also check in England. I don't know if you are familiar with England geography, but typically here it's Cumbria. Cumbria is an area very close from Scotland, and you can see here there is not a lot of pollution. And this is southeast London, where you have a lot of pollution. And if you look at the correlation in England between EGFR mutation and PM 2.5, you can see here that if you are living here, you have less risk to have EGFR mutated lung cancer than if you are living in East London. So it's very important. As there is not only UK, they did with biobank some international studies. They also checked South Korea. They also checked the same in Taiwan, South and North and South Taiwan. And you see that it's always the same story. The more you are exposed to PI, to particle matter 2.5, the higher is the risk of having a EGFR mutated non-small cell lung cancer. So there is a direct correlation between pollution and EGFR mutated lung cancer. What they did, they took some mice in which they induced EGFR or KRAS mutation. So they artificially, as I told you in the introduction, developed mouse model with EGFR or KRAS. And they exposed this mouse to, this mice, to pollution. I mean, they make them breathe some pollution. And you can see here that in, I think here it's EGFR models or here KRAS model, mutant model, you can see here that if you expose the mice to 5 microgram or 50 microgram of PM2.5 pollution, you will increase the number and the size of lung tumors. So you already have some EGFR and KRAS. In this pre-existing EGFR and KRAS tumors, if you expose the mice to pollution, you will increase the development of lung cancer. Okay? You can see here, it's quite clear. This is the control mice, lung, and here after you have bigger tumors and you have a higher number of tumors. Then they check all the development of lung cancer is based in alveolar type 2 cells, what we call in French pneumocytes de type 2, alveolar type 2 cells. So they check the molecular signature of mouse exposed to pollution, and what they observe that there is exposition to PM2.5 drive alveolar type 2 progenitor state transcriptional signature and macrophage recruitment. So that means that if you are exposed to this pollution, it will change the programmation of the alveolar type 2 cells that are the ones that will induce lung cancer. So it targets specifically these cells. And here they will also, so I think it's the same here. What they did also, it's very, very smart also. And they expose some healthy never smokers, so it's humans, normal mice, to pollution. It's just 2 hours, okay? So it's not, they don't say you will live 2 years but for 2 hours, and they do a bronchoalveolar lavage, and they analyze what was in the lung, and they compare patients who were exposed to pollution and patients who were not exposed to pollution. I mean, here it's filtered air control. And you can see that in patients exposed to pollution, there is an overexpression of many inflammatory proteins, such as interleukin-1 beta. So you can see here, all these proteins that are overexpressed in patients exposed to pollution. So what they propose is that when you are exposed to pollution, it will induce an inflammatory state mediated by interleukin-1 beta that will transform your cells, having in mind that we have in our lung normal cells some pre-existing EGFR or KRAS mutation. So it's very theoretical. So the next step was to say, do we have in normal tumors EGFR and KRAS mutation? So what is the answer? Yes, no? Half of us, or many of us have EGFR mutation in their lung. No? 25%, and KRAS 50%. That's what they found. They found that what they did that on autopsy and also on patient in which they check a normal lung. And you can see, so I say 20, so it's 15% of normal lung sample have EGFR driver mutations. It will not become a lung cancer, except if you have some pollution that will induce inflammation. And for EGFR-KRAS, they found 53% of normal samples display KRAS mutations. So it's quite frightening. So the conclusion of the paper is that we have, most of us, have some pre-existing mutation in our lung, such as EGFR, BRAF, KRAS. They have only 2 for EGFR and KRAS. When we are exposed to pollution through particulate matter 2.5, it will induce an interleukin-1 beta inflammation that will activate this EGFR mutation, and that will lead to tumor formation. So it's very important paper because that means that we all have some somnolent or pre-existing mutation, and that pollution or inflammation can transform these pre-existing cells in tumor cells. So I didn't add it, but if the question is, where should I live? So it's better to be in the south of France than in the north. And it's better to be in the mountains than in the valley. And it's better to be in the Pyrenees than in Toulouse. But 99% of the patients living in the world are exposed to a level of PM2.5 that is above the OMS, WHO cutoff. That means we are all exposed to pollution. That means we can all develop, independently of tobacco and or smoking, we can all develop lung cancer. So there is a lot of work on that to understand this, but it's very important because I think for all the young searcher you are, you have to keep in mind that pollution is the next. I mean, alcohol and tobacco are very important. I don't want to discuss about that, but I think we should all work on that. And I don't know if you are aware, tomorrow we have at Oncopol, we have a special session on pollution and cancer at 6 p.m. If you want, I will present that, but we have also myeloma and cancer. We will have a glioblastoma and pollution. So we have more and more cancer associated with pollution and not with way of life. Okay. So it was about EGFR. So just to speak a little bit about new targets. As I told you, we have more and more targets. Do you have any question regarding pollution? Okay. You have to come to work by that. So you have not to smoke and not to take the plane. So ALK is another alteration, but I will go, but it's the same story. We find some ALK alteration, and if you give crizotinib, it works better than chemo. And this is a very recent paper. No, that one is was published 4 years ago. That was the first report of lorlatinib versus crizotinib in a patient with ALK molecular alteration. So what was very important here is that you see crizotinib was doing better than chemo, but lorlatinib, which is even more potent to target ALK, you can see here that after 2 years, most of the patients are alive. So it's a very interesting drug. And I don't know if I had it or not. Yes, it was published very recently. We proposed an update of this clinical trial after 5 years of follow-up. And you can see here that at 60 months, that means 5 years, most of the patients are still under treatment and did not experience recurrence. So this is more like what we saw with Gleevec in hematology. We have now some new drugs, especially that one, lorlatinib, that you can see here, works in most of the patients, and it works well, and it works for a long time. So what is very important is here that after 5 years, we still have a lot of patients without recurrence. So this is an example, for example, of a patient who had ALK translocation. You see, he's still alive after more than 10 years of treatment, and he was treated with crizotinib, then alectinib, then ceritinib. He had experience with all the new drugs, and here he developed a BRAF mutation, so he had a combination of lorlatinib and dabrafenib. So for this patient, I think what is important is here, they have this kind of tumor development. You can see here that they have this ALK mutation, but sometimes you have some subclones that are popping up here. And so here, for example, you have to treat the patient with combination of drugs because you have several clones, or with new drugs that can target or inhibit all these subclones. So it's more and more complicated to treat these patients. Just to mention what has been published this year in 2024 for RET, RET, which is another fusion, very comparable to ALK. You can see here that we have a specific drug, selpercatinib, that works better than control. Control is chemotherapy. And you can see here, each column is a patient. Most of the patients have a response, and sometimes they have complete response. That means that a decrease 100% of the tumor. And you have here some side effects, so it's not very, it's well tolerated. So we have more and more drugs. So it has been published this year. It has also been published this year. It's a BRAF inhibitor with a combination of encorafenib and bilimetinib. So you don't have to, it's always the same story. We have the mutation, we have the drugs, and we try to find the best treatment. Here it's with HER2. So as we said, HER2 is important in breast cancer, but it's most of the time amplification. But in lung cancer, we have mutation, specific mutation in exon 20 of HER2. And you can see here some response with trastuzumab in HER2 patients, or here with an antibody HER2 antibody drug conjugate, which is trastuzumab deruxtecan. You know what is ADC? A mix of antibody and a drug. So the antibody targets HER2, and the drug deruxtecan is a conventional chemotherapy. So it works well. You can see here. We published that, I think it was last year. And you see that most of the patients have a response, but maybe less complete response, but most of the patients derive a benefit from the drug. So for HER2, we can now have access to this drug. Another oncogenic addiction, NTRK, NTRK. And you can see also that regardless of tumor etiology, it can be in cholangiocarcinoma, in melanoma, in lung cancer, you have very nice response with a lot of complete response. You see response rate is 80%. So it can happen in a young and elderly patient, in a woman and male, and in most of the time in never smoker. And the new challenge is to target KRAS, because KRAS is bingo if we can target it, because it's 20% of lung cancer. But KRAS is difficult to target. But you know the biology of KRAS, I think, because it's a very oncogene. You know that it's not a transmembrane protein, it's an intracellular membrane. It's cycled between a GDP inactive state and a GTP active state. It targets the MEP, RAF, MEK kinase pathway, but also the PI3 kinase AKT pathway. So we don't know how to block exactly KRAS. So a lot of drug has been developed to target KRAS in its GTP form, to inactivate its GDP form, or to target some co-activators of KRAS, including SOS, HAP2. So many drugs are currently developed, but you can see here some specific inhibitors of KRAS. Well, it's, anyway, one of the most interesting drugs, the first one is sotorasib, that has been developed in KRAS G12C patients. This was the phase 1, and the phase 3 has been published recently. It's written ESMO, but it was published in Lancet last year. And you see that sotorasib versus docetaxel, so a chemo, is doing better, but it's not, as you see for EGFR or ALK, it's working better, but it's not very important effect. So we are looking to new KRAS drug. And this has been reported very recently. It's not yet published. Crystal 12 trial with adagrasib. So it seems here also that it works better than docetaxel adagrasib in brown and docetaxel in green, but you see that we have a lot of recurrence. And new drugs such as divarasib are currently developed also. It seems to work better. So we have a lot of trials right now with divarasib or even other drugs that target KRAS. So I think if we can find good drugs to target KRAS, it will be a very great point, but because we can address this disease in 20% of lung cancer patients. You know that KRAS is important in colorectal cancer, in pancreatic cancer. So KRAS is very the target we need to inhibit and to focus on. I don't know if some of you are working on KRAS or KRAS. So this is the same story. So when we start here, we were here, and now we have a lot of drugs. So it's very good. And so that one was updated yesterday. So this is all the target we have in lung cancer. You have here the biology, if there deletion, mutation, insertion, etc. You can see here the percentage of patients affected by this alteration. And here you have all the drugs available in France. When it's underlined, that means it's available and reimbursed. When you have here small asterisk, that means that you need to have early access program, what we call accès précoce. So you have to ask to get the drug, but we can get access to the drug. And you can see here drugs that are developed in clinical trials. So this is very important. This is, I will say, the best slide regarding personalized treatment. Personalized treatment, that means we don't treat all the patients the same way. All these patients have the same name, lung cancer, the same disease, but you see that we have some more than 10 drugs available depending on the molecular alteration. So that means that you cannot treat a patient without having the molecular profile. So you need to have the molecular profile, the target. You need to give the right drugs, and we will improve lung cancer development. So I speak of lung cancer because I'm a specialist in lung cancer, but and because this is a disease in which we have the more important drugs, targeted drugs, but we have the same for melanoma with BRAF inhibitor, with breast cancer, with HER2 inhibitor, with GIST, with c-KIT inhibitor. So in most of the tumors now, we have this kind of table with abnormalities, biology, and drugs. So that's a good point. That means we have plenty of possibilities for patients. And that I change this because I give a lot of talk regarding it. I change this every 2 months or 3 months because it changed, and we have new drugs very, very frequently. So that's a good point. So how to deal with that? Because even if we are aware of biology, sometimes it's complicated to distinguish which are drivers. Among drivers, mutation, which are clinically actionable. For example, if you have a KRAS, a G12R mutation, okay, it's a driver, but we don't have drugs. So, and we have also a lot of anomalies. Sometimes we see this BRAF T332 mutation. I mean, it means nothing. You have it on the report. You say, well, it's BRAF. Well, you check, no papers, no drugs. So we have to be very cautious and to distinguish some what we call passenger mutations. They are just passenger. I mean, you find them, but they are not driver. You can outside have driver mutation, and in the driver group, we need to identify the one for which we have drugs. So this is what we are doing every Tuesday in Molecular Tumor Board, where we have the report for all the patients, and we try to find, does it mean nothing? It's here. Are there drivers, but we don't have drugs, so we try to enroll them in clinical trials, or are they clinically actionable? Typically, This is a report we had, so it's an old one. For this patient, we did a liquid biopsy because she was a never smoker, and we found that this patient, she had ERF3 amplification, NF1 loss, CDK4 amplification, NDM2 amplification, APC mutation, CDKN2A loss, FRS2, I don't even know what is it, amplification, V1 amplification. So which treatment? What we You are a biologist, so we ask you, you are doing, you will have your diploma, so we ask you, what should I do with that? So, is it important or not? I will say maybe, HER3, maybe, CDK4, we know that cyclin-dependent kinases are important. Okay, maybe. Do we have drugs? No. So that means you have this, you're pretty happy to have this report, but at the end you will give chemotherapy. So you see, sometimes there is a discordance between the report and what you can do. So here there is nothing that is useful. Probably it means something. Maybe in 10 years we will give something, but now we don't know what to do with that. So it's complicated. And let's see, I don't want to distinguish Toulouse between other, but if you are working, I will say, in Rodez and you receive that and you didn't have any experience in biology, it's complicated, you don't know. So they call the hospital and we say, no, there's nothing to do. At the opposite, when you have this MET exon 14 mutation, we have drugs, perfect. There is only one, but it's a good one, so it's okay. And this patient, I always add this, because she was almost dying. She already received 7 lines of treatment. And this report is from 2018. You see, it's a real case. And she's still alive. She's still treated with crizotinib, which is a MET inhibitor. So you see, it was when she had the recurrence and she's under treatment. So sometimes this kind of report can be very useful. And sometimes we have the right target and the right drug. So now this is the second part. Are you okay? This is the second part of the talk regarding resistance. Because it works, but at the end, all the patients will develop resistance. So that's good. This is something I already showed you, the resistance to EGFR mutation. Here you have the chemotherapy curve, but here you have the targeted therapy. So it works better. Alotinib is doing better than chemo. But we have some recurrence at the beginning. That means that some patients have primary resistance. You have the target, you have the drug, but it doesn't work. Sometimes they have a recurrence within the first year. And sometimes they can have we have some long survivor, and they will develop secondary resistance. So it's complicated. Here, this is an overview of what we observe. All the targeted drugs are working well. You have here osimertinib, EGFR, aletinib, ALK, dabrafenib, BRAF, crizotinib, ROS1. It works well in most of the patients. But if we look at the PFS, progression-free survival, at some point, all the patients will have recurrence. So that's a problem. Now, the question is not to give the good drug, because we have the good drug, but how to avoid or to delay resistance. So for you, what mechanism of resistance to targeted therapy are frequently involved? Onset of resistant mutation. That means you don't have this mutation at the beginning and you will develop this new mutation. Yes, okay. Transformation in another histology. That means at the beginning you were adenocarcinoma, and after exposure to the drug, you will have a squamous carcinoma or small cell carcinoma, kind of total reset of your tumors. Yes, it's not very frequent, but it can happen. It's very intriguing. Involvement of other signaling pathways. Yeah, that means you block the highway, you will take the other way. Change in the target itself. Yes. Yes. And immune escape. Immune escape, last year, I will say it was wrong. but now I think it's, yes, I changed the slide. But because at the beginning we were thinking that the immune system was not important in targeted therapy and in patients with oncogeneration, but now we have more arguments, so I think it's true. So everything is true. Okay, so everything can happen. So as I said, you can have on-target mechanism of resistance. That means the modification that will drive resistance is at the target, such as gene amplification, EGFR amplification, ALK amplification, or new mutation. For example, for EGFR, one of the most common mutation of resistance is the C797S mutation. You treat patients with osimertinib, it works for 2 years, 3 years, you do a rebiopsy, and you find this mutation that is exactly very close from the primary mutation. That is another one, and it's a resistant mutation. For ALK, one that is very famous is J1202R mutation. So for ROS1, it's another one, for RET, it's another one. So we can have some new mutation within the gene frame that will lead mutation. At the opposite, we can have some off-target, including, it's not on the target, you still have your EGFR, your ALK interaction, but we have some lineage plasticity, such as transformation to small cells. It's something like 5% of adenocarcinoma treated with EGFR mutation. At the beginning, you have adenocarcinoma, you treat with osimertinib. After 2 years, you rebiopsy and you have a small cell carcinoma. It's incredible, right? Because it's totally different disease. That means you have kind of a reset, it goes back to 0, and you have a recurrence in a different way. Because when you work on lung cancer, small cell and non-small cell are totally different. It's not the same cell of origin, it's not the same genetic alteration, it's totally different. And here it's very intriguing to see that it can come from one to another. And you can have involvement of alternative pathways, such as amplification of HER2 or MET, mutation of RAS, PI3 kinase, gene fusion, cell cycle alteration. So everything can happen. Can we know from the beginning what will happen? Can we know from the primary tumor? If it's possible, it will be good because we can anticipate and maybe propose some combination, but no, we cannot. So here you have, you see that it's not specific to EGFR ALK. It's the same story for all oncogenic addiction. You can see here that for ALK or for resistant to lorlatinib or resistant to osimertinib, it's exactly the same. It's not the same name. Here you have the C797 mutation. Here it's another one. But you can have some target alteration. You can have some other signaling pathway, or you can have some change in tumor histology, small cell transformation in both cases. So it looks like it's always the same story. When you have a targeted therapy pressure, it will induce either genetic alteration in the gene, activation of the pathway, or a transformation in another histology. It's always the same. So can we do better? So yes, can do better. You can do. This is what we observe in patient. You have this lung disease. Here it's left lower lobe. You have a disease. You treat with, let's say, osimertinib, erlotinib. You have a complete response. Very good. It lasts something like 1 year, 2 years, 3 years, and after you have a recurrence. It's the same in mouse model. It's the same in cell lines. You treat, you have nothing, you get rid of all the cells, and then at the end, you have a recurrence. So it's kind of unavoidable recurrence. So that's pretty complicated. So the question is, what are the mechanisms of resistance? But to understand the mechanism of resistance, we have to wait the resistance. I mean, we have to wait to see the recurrence and to rebiopsy to understand the recurrence. So it's okay, but sometimes it's a little bit too late. For example, if you rebiopsy patient treated with osimertinib, you can find all these kind of mutations. Sometimes you have nothing, you don't know the mechanism of resistance. Sometimes you have histologic transformation. Sometimes you find BCGFR mutation, or new amplification, or oncogenic fusion, or other gene alteration, or other pathway. And in all cases, you can add some other treatment. It's targetable. Oh, yeah, it's the same in second line, but well. So you see that it's very heterogeneous mechanism of resistance. So it's complicated. We have to wait to the recurrence to rebiopsy to understand the mechanism and to try to find some new strategy. What are the new strategy? There is a lot of clinical trials. Here you have an overview.
You want me to check?
I am so confused.
So I wonder if then you're paid via the XCP. So probably we should put XCP side or
Is that true? Yeah, I am.
I do not know. What need I?
C'est pas pour moi. Mais je peux éteindre la. C'est bon.
I thought
So, yeah.
Antitumoral has one number and then different numbers.
Je peux pas la limiter.
It should be FR whatever. Don't we have one number like that?
Antitumoral has two numbers, I think.
Is that true?
Yeah, which two numbers?
I remember he has two and then another STP, so it was three at the time I started.
So we don't have one number for us in general.
Yeah.
For him.
First one, I think, is the co-grant, and then
Yeah.
second one.
So this is the household, this is the XTP, and this is the yeah. So I'm not sure if they put this FR or this number, but if it's, I guess your salary is from the XCP, then you should put the XCP number, but I don't know if it's then this number or this thing.
Le meilleur pour la fin, en fait.
They say cost center. If they would ask cost center,
If we cannot find any resistant mechanism or non-mechanism, we treat with chemo. I mean, we don't. If we have amplification of on-target mutation, we can add new drugs.
Yeah.
If we have
I would
severe
just put
amplification, we also can
FR02.
add a new drugs targeting this
it is not
this
enough.
new mechanism of
Yeah, because I
resistance.
mean, you see here, they are
But
all
I think the most
FR02,
important
so they
thing
don't know which
is to
one.
try to understand the mechanism
I
of
don't think that's an
resistance,
issue because
not
the
at the late stage, but at the early stage. If we try to see from the
Yeah, no,
beginning,
it's good too,
we
because
can
I was
find
wondering
some
how if I don't,
mutation that
I
will
would
use
have
the
to make a
resistance.
fake
It's important. For
order
example,
to
if you have a
do
T790M
I
mutation
don't
from
think
the
it's
beginning,
irrelevant
but
because in
it's
any
a
case, this is
minor
gonna be over in
clone,
June.
but that will through a Darwinian
My-
selection will develop and drive the resistance. You can imagine that we should target T790M not when we have recurrence, but from the beginning. That's why we use new generation tyrosine kinase inhibitors such as lorlatinib for osimertinib because it can target this from the beginning. So we use the best drug in frontline.
Also because
And
my
it works.
contract is not.
Now the
So
real
the
question,
application
and I
goes
will
over the
touch
expiration
on
of
that,
my contract.
is
It's
can
not
we
going on this anymore.
understand
because this
and
expires
identify the resistance at
So
the
this is
time
why I
of
don't
response?
think any of this is
Because I think
relevant
it's here
at all.
when you think everything is okay, that it will drive the resistance through what we call drug tolerance cells. Are you aware of drug tolerance
Because
cells?
FR02
So
would be DKK Freiburg, so
When you treat
the other
patients,
DKK
you have this
Freiburg, they
response
also
with
have
targeted therapy.
FR02
You
and
think
then other
it's a
stuff.
complete response, but it's not a complete response.
I'm not
All of the
familiar
time,
with
even
this
if you see nothing on the chest scan, if you see nothing in the
I
mouth,
will put
you have
FR02
some
if
residual
she
disease,
can come back to me and tell me we need more.
some cells
She's
that will
Andreas Munch.
be infraclinic, you won't see them,
So
you
if
think
HR doesn't know
they
this,
don't
I
have
don't
any
know
more
who
to
should.
but at the
I
end,
mean, you
it
can
will
ask
drive
them.
resistance.
Please, might be
So,
more familiar
there
with
is
these
two
things.
explanations. The first one is we have some pre-existing clone that will grow up. This is what we call the
Probably,
Darwinian
as you
adaptation.
said, FR02 is probably
As
not
you will
precise
treat
enough.
with the
Yeah.
drug the
But
blue
I see the
cells,
point,
at the end,
the
the
final-
red
None
cells
of the
will
three
be alone and will
are
develop.
somewhere.
or
At
it's
the
not for
opposite,
time.
we can, this is the.
In any case,
the-
no. In case
la
she
révision
comes
à
back to me, I
l'autre,
will
ordre de Darwin
bring it
Lamarck, so
again.
Lamarckian adaptation
It is fine.
with the drug pressure, the cancer cell line at the end, what they want to survive, they will develop in turns, even if it's not present at the beginning, some kind of mutation that will drive resistance. So this is what we call drug-tolerant persister cells, DTP cells, and what a lot of teams are currently working on that, try to understand why this residual disease will drive the resistance. So a lot of paper has been published, including a very recent paper. I think you will work on it in the workshop from the lab. We worked on this residual disease or drug-tolerant persister cells, and we try to understand what are the molecular pathways involved in that, because I think we cannot treat with the best drug frontline. If we wait here, it's too late. So we have to understand what happens here and to add some specific drugs here. So we need to understand the early adaptation of tumor cells, the dynamic of the drug-tolerant state, and the acquisition of genetic and sometimes non-genetic resistance. For that, we can work, maybe if some of you are working on that in labs. We need some cell lines, some organoids, some tumor chips, some genetically engineered modified mice, some PDX, some patient analysis, and all, we are aware of that, RNA sequencing, single cell RNA sequencing, special. We need to understand what happens here with all these models.
Mark is also sick.
As an example, you can see here a drug tolerance. We have this drug tolerance cell. If you see here, you think that the patient is cured or this is PC9 mutated cells, you had some erlotinib, it works, but at some point, you have a cell division. That's what happened in patient. It works. You think that the cells are dormant. You think they won't be able to divide or to drive recurrence. But at the end, you have this mitosis, and at the end the recurrence. And you can see it's the same. Yes, it's something else now. Yeah, and you see, if you wait a little bit more, you have some cell division, and then this will be the recurrence. And in the meantime, it will induce some genetic alteration that will induce the recurrence. So, when I say we, it's just not in Lille, Blues or the team, everywhere, we try to work on this to understand the biology of drug-tolerant cells to specifically target these cells. So, something I always say. So, just to let you know that, I don't know if you're working on drug-tolerant cells, but this is a very important topic. This paper has been published in the last months. So you have two reviews in Nature Review Cancer and Nature Cancer. So that means I don't speaking about something that is only for one team. It's very important. So you can read these two papers. If you have to select one, that one is better. And cancer drug tolerant persister cell from biological question to clinical opportunities. So it's very, very important topic. This is the paper we made in the team. Also in the review. So this is our paper. So as I told you, we have this primary resistance, but acquired resistance through this step of minimal residual disease. We start from parental cells. We have this drug-tolerant persister cells, and then we have this DTP-derived resistant cell that will occur and induce resistance. This is issued from this review, so that one from this team, and what they say is that what we observe in drug-tolerant persistent cells is the same as what we observe in bacteria resistant to antibiotics. So it's a little bit the same story. I don't want to spend too much time on that because it's quite complicated, but I suggest to you to read this paper. And you can see here the definition of what are bacterial persisters. So I know they are not working on bacteria, but you have here this description of drug-tolerant persistent cells. And the difference between cancer stem cells, it's drug-tolerant cells are not cancer stem cells. They are not dormant cells, and they are not senescent cells, even if they share some characteristic with cancer stem cell. So here you have the markers that are different. The proliferation, what is really important is that even if they are looks like asleep or dormant cells, they can display have some proliferation in a subset of tumor. You are here the difference in metabolism, in microenvironment, heterogeneity, and genetic evolvability. You can see here that cancer stem cell, tumor dormant cells, and phenol stem cells cannot display genetic changes, whereas drug-tolerant persistent cells, they can have acquisition of resistance. So if I have a suggestion, you should work on that. That's the future of oncology. In the same review, they explain what are the mechanisms known in these drug-tolerant cells. And you can see that we have some cell reprogramming through epigenetic remodeling, transcriptional rewiring, translation rewiring, metabolic also features. Here you have the phenotypic adaptation, the modulation of tumor microenvironment. That's why I said that I think that immune escape is more and more reported in the mechanism of resistance and some genetic adaptation. So you see that here also, even if they have all the same name, tumor drug-tolerant cells, you can see that it can cover many genetic, phenotypic, or microenvironment differences. So this is what we did, but it's the same thing. It can go through epigenetics, some sensory reprogramming, some metabolic reprogramming. So it's always the same story. And also, I think it's from the same review. The question is, can we target these drug-tolerant cells? For the moment, we understand we can identify this phenomenon, but can we target them? So what they say, here they say that we can either try to use drugs that will target specifically these vulnerabilities. Here, they say that we can also target the microenvironment or the plasticity and evolvability of the drug-tolerant cells. And here, they say that maybe what we should do is pulsative treatment. You treat, then you stop. You retreat, then you stop, because it's when you treat without interruption that you will induce this kind of drug-tolerant cells. So I don't know for a patient, if you say you treat your treatment for cancer 1 week on, 1 week off is a good idea, but well, that's a proposal. So this is an overview of if we want to target these drug-tolerant cells, what has been published. If we don't understand, we can give chemotherapy. Well, I mean, it's a step back to give chemotherapy, but in combination with targeted agent. Anti-angiogenic agents. Some senolytic drugs, maybe you're aware of these drugs that are targeting the BCL2, BCLX apoptosis pathway that are used in hematology. Epigenetic drugs, such as histone deacetylase or methyltransferase inhibitors. AKT inhibitors. Don't remember what is TAE, well, anyway. Aurora kinase B inhibitors, or what we published recently in the team, farnesyl transferase inhibitors that can address some molecular feature of microenvironment of these drug-tolerant cells. So you see that it's quite complicated, but it's a lot of teams are working on that to understand the biology of drug-tolerant cells to target them specifically. Okay, at the end. Do you have questions? Are you working on that for some of you? Working on CR thinking? CR thinking? When you work on the for the team, but okay, that's
there question mark on zero?
Yeah. So Mariam used it or did some media, and then she saw that there is kind of debris on the bottom in the Sierra. So I told her, yeah, maybe she should put a culture in warm and see. I checked it today and put a sticker on the Sierra so that people don't touch it.
What if I need zero now?
She thought another one normally. There should be, if she didn't finish it today again.
There is no.
Because she did, yes, last week, a new Sierra. She saw the new Sierra as well, but she used it this morning, so I know.
So there is still a bottle of zero. Okay.
Yeah.
primers.
Oh, I'm sorry.
Covers. If you find them, could you give them to Maria? That's. Or. Don't have to do this way. Find them or they're not or.
Many different combinations.
Names, information, and then I'll give it back to you.
That if the meeting is cancelled, right?
Not, oh, yes, because I also have a meeting with Mark tomorrow, 1 to 1, he didn't mention anything.
Okay, probably we know tomorrow.
Mark said he will decide on.
That's what I expected. Yes. If he decides not to come, we should get worried because even with COVID, he was taking flights. By the way, Timothy, the Origin software with the newly created Unimail and everything, it worked perfectly.
Okay, good.
I had to deactivate it from here to activate it at home.